Good day, everyone, and welcome to another GlowPack series of webinars focusing on the new CKD Lancet series. Today, we're going to have a conversation about how we can use this Lancet series to advocate for advances in timely chronic kidney disease management. Joining us today, I have some wonderful friends of GlowPack, Valerie Lakes, who's a nephrologist and kidney health advocate. June Fabian is a nephrologist herself as well, affiliated to the Wits Donald Gordon Medical Institute and a contributor to this Lancet series. And Stephen Matiso is a policymaker at the Kenya Ministry of Health working in the renal program. Together, they are going to help us talk through the Lancet series and explore different opportunities that it presents to us to strengthen early detection and timely CKD management, both in clinical practice as well as health systems and policy. They're also going to help us illustrate how the series can inform country-level implementation. We're looking forward to having Stephen contribute his insights and expertise on that part of the conversation, and then help us to think through what the key messages are we can extract from the series and the conversation here today to inform how we continue advocating for improved kidney health outcomes in our context. This webinar is brought to you by the Global Patient Alliance for Kidney Health. It is a global collective of over 40 patient advocacy organizations from all around the world working together to ensure that we have better access to screening, early detection, and early treatment of chronic kidney disease. Please share your questions and comments in the Q&A function of the Zoom. We will try our best to go through all of your questions, time allowing. I'm happy to hand over now to you, Valerie.
So thank you very much, Leander, and to GlowPack for hosting this wonderful webinar, because I think it's a unique opportunity after this wonderful Lancet series, which is following closely on the heels of the World Health Assembly's adoption of the first ever kidney health resolution last year in 2025. And basically, this Lancet series is essentially highlighting how chronic kidney disease is a very rapidly growing health crisis. We know that it's well over 800 million people around the world who are affected, but almost most of them actually are not yet aware of it. And so it's extremely critical that we improve access to diagnosis, access to care for kidney disease to try to reduce the mortality and the burden, and especially the burden for those living with kidney disease. Kidney disease is projected, if we do nothing, to become the fifth leading cause of death by 2050. So it is a big problem. Kidney disease also is very interlinked with cardiovascular disease and multimorbidity. So we really need a holistic approach, and we need, therefore, kidney care to be very well integrated into national non-communicable disease and other disease programs. And I think what also this Lancet series highlights is that we are in a very exciting time. There are game-changing medications now for kidney disease to slow kidney disease progression, prevent cardiovascular complications, and actually prevent deaths. But these medications are very inequitably accessible around the world, and this also needs to change. So a lot has grown in kidney. We've got a lot more awareness of the potential burden. We now know how we can diagnose it, what we need to do, but we need to start really detecting people, treating them with quality care, and hopefully therefore improving their lives and their perspectives. So I will now hand over to Dr. June Fabian, who's going to be doing the first presentation. And she's going to be speaking. She was one of the authors of the Lancet series, and she's going to be speaking on the advances in screening and diagnostics for kidney disease. So over to you, June.
Thanks, Valerie. Can everyone see my screen? Just trying to transition. Okay. So again, thanks for the invite to participate. It's very exciting to see this. And I'm very excited that Stephen's here, because I wish I could clone him and take him back to South Africa. But you'll see why in a few minutes. But for now, I was given quite a strict brief by Luyanda about what I can cover in 8 minutes. So we're going to look at an overview of the Lancet series, essentially trying to focus on why this matters, and what the key messages and calls to action are. And then focusing a little bit more on advances in screening and diagnosis, and then also, as Valerie said, managing CKD alongside lots of comorbidities. So why does this matter? Why it matters is because when the World Health Assembly and the Lancet series say CKD is important, it's much harder for our public health policymakers to kick the ball down the road. And the reason people do that is simply managing priorities. So before on the NCD agenda with the World Health Organization, it was cardiovascular disease, respiratory disease, cancer, diabetes, and mental health. And I always remember when a very dear colleague of mine in Uganda, Robert Kalesabula, said to me, I went to the Ministry of Health, and the first thing he said to me is, how many malaria cases can I treat with the money you're asking me to invest in dialysis? And he said he just looked at him and he walked out of the room. And those are really, really difficult conversations to have because it's always about what do we have and how do we distribute that given all the health challenges we have in our settings. And that's particularly relevant in low and middle income countries as well. So for example, in South Africa, we've had a massive focus on maternal and child health and on HIV and infectious diseases, all completely justifiable. But every time we've tried to put kidney disease on the agenda, it gets wiped off the agenda because one of the examples is it's not part of the big five, according to the WHO. We also do quite a lot of work in one of the rural parts of the country, in rural Bushbuck Ridge. And when I was talking to the team there, we were saying that people with kidney failure become the shingumana. It's a Tsonga word for they become invisible. And that's because without treatment, they die and we bury them and we carry on. So I think those are some of the really sad realities in our settings of people who cannot access care. And while we all agree that dialysis is not the only treatment, very often in low and middle income countries, there is an investment in dialysis, but there isn't an investment in early detection and treatment. So what we're really hoping for is that the WHO resolution is now saying, it's putting out there that kidney disease really does matter. The Lancet series tried to say, what can we do about this thing that really does matter now? And as I mentioned to you, kidney disease is now on the agenda as one of the major NCDs. And that also represents a shift in how people think, because a lot of people think that NCDs are a consequence of something else. So if you have diabetes, you might get kidney disease. Or if you have cardiac failure, you might get kidney disease. But now that it has space as an entity in and of itself, we all have to shift the way we think about it as well. And I think there's also been a very important shift from kidney therapy replacement is really expensive because that's what everyone tells us when we speak to the Department of Health. But what we now know is that there are much cheaper drugs that are available that if we screen and detect people early and delay their progression, and that is one of our best public health buys, and that's what we need to convey to the policymakers. So looking at advances in screening and diagnosis, I think exactly what Valerie was saying, early diagnosis has become worthwhile because the therapeutic landscape has fundamentally changed. So before people would say to us, well, why should we screen if all you're going to tell us is to treat the cause? So if someone has diabetes, we'll control the diabetes. And if they have hypertension, control the hypertension. But now we know that there are a whole gamut of drugs that are now becoming available. SGLT2s are now coming off patent. We have MRAs, we have GLP-1s. And all of those allow us to risk stratify, identify people at high risk of progression, and ideally get them onto treatment to prevent the progression of their disease. So a lot of the speak has become actionable because we have different tools in our toolbox to be able to treat people. I will make the point, though, as Valerie also alluded to, is that this also depends on where you live in the world. In many low and middle income countries, diagnostic tools have not been validated for assessing kidney function. They don't always work as well. Our public health screening and treatment algorithms are not defined. And people say, well, just test. And point of care in those situations is the most pragmatic, hasn't always been supported. But then the question is who? So Robert, who I alluded to earlier, and I have done work in Africa, and up to 40 to 60% of people in Africa do not have traditional risk factors for kidney disease that are commonly referred to in high-income countries. So the question about who to screen is still not that clear. And then the other kind of dictum is, we'll test and treat like we do for HIV. And then the question is, with what, if a lot of the drugs we don't have access to? So I think pragmatically in our setting, just being able to have access to SGLT2 inhibitors would be an amazing leap forward. The other thing also is about integrating care. A lot of our care is very silo-based, and we can't do that anymore. What we'll end up doing is sending a patient to an HIV clinic, then they go to the hypertension clinic, then they go to the diabetes clinic, which is totally unsustainable. But for example, in South Africa, we have been able to build that into models of care with HIV. The downside of that is it required substantial investment. And it's an investment that isn't being made in NCDs, but tends to still remain in the infectious diseases space. And the other thing also has always been about the workforce. Everyone says, we need more nephrologists. I don't know if we need more nephrologists because it's not a solution we'll be able to do. But maybe we just need to train primary care healthcare workers, community healthcare workers, to be able to screen and detect and then refer into care. So my last kind of 5 cents is managing CKD alongside comorbidities. There's a lot of work, I think, more in high-income countries around cancer and CKD. To be really honest, in low and middle income settings, it hasn't really been much of a priority because I think we're still trying to focus on all sorts of other things. But I do think that CKD should no longer be viewed as an isolated thing, but it's part of a network of chronic diseases. And I think a lot of them share common pathways. A lot of our CKD is inflammation, a lot of it is metabolic, and a lot of it lands up in a pathway that leads to fibrosis, at which point we can't pull anything back. Similarly, with liver disease, it's metabolic, it's fibrosis, it's end-stage liver disease. So our patients are becoming increasingly complex. And I think what we also not prioritizing is that there is a role for acute kidney injury, and acute on chronic kidney injury often pushes our patients further down the line towards progressing with their kidney disease. And I think the impacts of that are often missed. Often in our setting, for example, if someone gets malaria and dehydrated, or if they get schistosomiasis, or if they get TB and they're on nephrotoxic drugs to treat their TB. And I think all of those things is about an awareness and screening and being able to try to prevent the complications related to that. So I also think CKD can't just be the nephrologist's responsibility. It needs to be all of our responsibilities. Primary care, diabetes, hypertension, HIV services, all of those. And as we all age, which we all know that we are, our aging populations are also increasingly vulnerable. And those are all things that need to be built into our care. So our challenges for that is multimorbidity. We're finding, particularly in Africa, women have HIV, they have perhaps TB as well. They also become hypertensive, they put on weight, and then they become type 2 diabetics. So you can have one woman who maybe started with one illness and 5 or 10 or 15 years later has 4 multimorbidities, all of which need to be managed. And that also leads to polypharmacy, which can damage kidneys, and also fragmentation of our health system, which I have referred to already. So I think our key take-home messages from the WHO kind of acknowledgements of CKD as one of the big ones, and also the Lancet paper, is that CKD is now a global priority. We cannot pretend that it isn't anymore. The early diagnosis is worth making because there are things that we can do about it, and there are things in our toolboxes that we never had before. It's no longer considered an isolated thing that happens separate from everything else. And we need to change the way we build that into our workflows. And then I think probably the greatest challenge for us now is implementation. So I'll stop there and hand over to Stephen.
Hi, June. I don't know if I'm audible. Valerie, is there a rejoinder for me or do I just go?
We can hear you.
Thank you. All I
Wonderful.
would just say, Stephen, is I think we definitely agree we would want to clone you. It's just phenomenal to have somebody in a ministry who's so engaged with kidney disease and the broad spectrum of kidney disease. So a huge privilege to have you here. So please go ahead.
Thank you. Thank you very much. It's always a pleasure to be in such a wonderful forum. Thank you so much, Layanda and the team. And I'm always honored to be in the presence of my great mentors, Valerie and June. So I think the only thing I could say is that probably my take would be that it's more complementary to what June is saying. So perhaps from a Kenyan perspective, what I see is the Lancet series provides certain opportunities, and I read through those papers, very exciting papers. And the first thing that came to mind to me is that we are trying to move into a preventive sort of approach in Kenya rather than a curative approach. We've tried it, it doesn't work. We're not able to dialyze our way out of this problem, regardless of how much vigor we have. And I've gone through quite a few hairy experiences. I think Valerie would know when it comes to the peritoneal dialysis, almost supply chain breakdown we had recently. And we just keep having all these very expensive interventions that are not quite reaching the people. They're not making economic sense. So we finally have an evidence base to sort of premise our response now to a more preventive route. And I like the fact that June has brought out quite clearly that we can actually prevent CKD. A lot of CKD is preventable. We could use simpler tools, a simple urine test. We can read that off a smartphone. We can do simple blood tests. And I think this week, I'm actually in a different town called Nakuru where we are doing the health technology assessment for primary healthcare. And last week, I was doing the same for the more complex sort of interventions for CKD. But I always make sure that I bring a wonderful gentleman called John Gikonyo with me, who is a wonderful guy who's head of the Renal Patient Society of Kenya and is living with a transplant. And we always say that we need to have our patients in the room. They always add so much value to these conversations. So it's not just the economists and it's not just the policymakers. We want to be all of us in that room. And we're really leaning on the WHO documents, the UN General Assembly high-level political declarations, and we're really trying to translate this into practice. And hopefully at the end of this exercise in a month or two, we'll have improved benefit packages for screening and early detection, as well as through the spectrum of care. So those are just some of the thoughts that I think I wanted to bring to the conversation. Thank you, and back to you.
So thank you very much, both of you. And I remember, Stephen, you actually put on LinkedIn that chronic kidney disease is the fourth leading cause of death in Kenya. Is that correct?
Yes,
So,
it
I
has
think
jumped.
we tend to think of it really as a high income country problem, but I think it's partly just because it hasn't been measured, hasn't been considered. And I think, as June was saying, it's not been prioritized along with other priorities. And I think this is a huge message that the kidney community is constantly trying to say. We don't want kidney disease to displace anything, but we want kidney disease to get into the room. And I think at least the door is open for us now with this resolution. So thank you very, very much for your wonderful presentations. I think very, very clear. I think, June, you sort of briefly alluded to it. Which actual screening strategies would you suggest? Is there a hierarchy? How would you prioritize them? Where would someone start?
Yeah, I think just to what Stephen was saying, a urine dipstick and a creatinine EGFR would be a great start. There are challenges. They might not be ideal, but it's better than doing nothing. And I think there's been a lot of resistance, definitely in the high-income communities around point of care. So what has been happening is because people don't support point of care, then nothing happens. My stance on that is that I would rather use point of care than not screen at all. And as Stephen says, there are app-based features coming through where people can take a photograph of a urine dipstick and it can quantify what's in it. So I think that's where digital technologies can help to move us forward. Because if we can do that, we don't even need to send it to the lab. So for example, in our rural setting, it can take it can take the clinics 24 hours plus just to get the samples to the lab. So I think if we could try and real time as much as possible and get people initiated onto care rather than creating multiple barriers where people have to come back, maybe the results are there, maybe they aren't. I think all of those things are barriers to implementing care, actually getting people onto treatment, even if it's an ACE inhibitor, not even an SGLT2. But if we could just start with simple things like that, I think that's low-hanging fruit before we start talking about GLP-1s, for example.
Thank you. And I think that makes a huge point, is that the point of care, and I think we still do not exactly know how well they perform in these environments. So I think we should definitely not throw them out of the window. I think they're extremely valuable, and they've been game changers for infectious diseases, for example. So I know that there's a lot happening on that front, and hopefully also we can find a way to track the data somehow. But I think one of the problems with labs often is that the results are not always that reliable either. So it's not a panacea. And plus the idea that someone has to pay out of pocket, come to the clinic, get the blood test, then come back, and someone has to find the piece of paper where that person's blood test is written on the right person, very complicated. So totally agree that at the time, it would be ideal to be able to then also counsel the person, at the same time. So Stephen, just thinking a little bit more broadly about that, and June mentioned sort of digital technologies and innovation. How do you think governments can sort of embrace innovation while trying to possibly even support or even improve equity of access in resource limited settings?
Yeah, thank you very much, Valerie. I think that's a very valid point. There's this tension that exists between having innovation and having it equitably distributed. So you might have newer technologies, but what we're seeing is that sometimes if your country cannot afford these newer technologies, they just widen the gap to access. However, at the same time, I feel like you don't necessarily have to have the highest end cutting edge tech. You can actually look for what is the best buy for your country. And I feel that point of care and the urinalysis, those are actually like highest value that we can draw from any of these interventions is looking at the high risk populations, having a point of care, having a trained healthcare worker who can identify if this is an abnormal test, and then creating that linkage to referral. And I think you've mentioned it quite succinctly. Pieces of paper that get lost, and you can't seem to track what's happening. There's a lot of time in between in the referral chain, and I feel like technology can be leveraged. We have this sort of system, digital health system. It's called the digital health superhighway in Kenya, and it does exactly that. So about a month ago, 2 months ago actually, we started to track the diabetes and hypertensive patients and link some testing for them, and at least now we have a fixed point of reference where we can see what's happening across that chain. And in the exact same way, this actually allows us to see prescriptions that patients go on. And I think June has mentioned it. Some of the medicines actually are now on the essential medicines list and cascaded to the lower levels so that we can actually start some kind of treatment as early as possible before we link to a nephrologist. I don't think we'll have thousands and thousands of nephrologists coming out in the next few years, but primary healthcare can sort of turbocharge that space. And I feel like the underlying engine for this would be your digital health and innovative spaces. And we have no shortage of people with ideas. We just need to support them and bring government into that understanding. And I suppose that is the bread and butter of what I do every day. I hope we can bring this to scale. Thank you, and back to you.
Thank you, Stephen. And I think hopefully the digital tools can also extend to sort of clinical decision support. But one thing that I think is also very important, at least what I've observed in many clinics, is that there are a lot of stockouts of the medication. And so I think, it's good that they're on the essential medicine list, but we need to figure out ways that these medications, and as well as the diagnostics, are actually affordable and that they're always on the shelves. And I'm thinking maybe some sort of digital tracking of that would probably not be a bad thing, may also help you to sort of track your costs and also estimate the needs. So that can help with the ordering and the primary care and things like that. So I do believe there's a lot of space where we can use sort of innovation. Could I just ask each of you very, very shortly to give one key message from the Lancet series that sort of has stayed with you and you think is important? And then I think we have a couple of more minutes and then we're going to have to wrap up. June?
Sure. That's really hard. I think I would urge anyone in the health space to think kidney, because I think it's something that somebody else has to think about, and we all need to start thinking kidney. Yeah.
Great. And Stephen, just before you give your 1 minute little quick summary, there's a question for you. How can we work with governments on procurement of generic medications? The SGLT2 generics are apparently 10 years per patient. So how do you go about this as a government in terms of negotiating and understanding the good prices and where to get things from?
Yeah, this is actually a very interesting question. I think one of the things I can think of right off the top of my head is as we're designing this health technology assessment exercise, we're doing quite a bit of costing, and we're finding out what's different market rates in the public, in the private sector, in the faith-based, and the church-related hospitals. What are the costs looking like there? And slightly beyond that, we started to look into some kind of a pooled procurement arrangement around the East Africa community. So there's 8 countries, and some of them are pretty similar. So you will find me talking to Professor Robert Kaliasubula in Uganda quite a bit, because we have a lot of links and things like that. So looking forward, that's what I would imagine this kind of cost equity conversation could be addressed. Are we there yet? Perhaps not, but there's ways in which I feel, in diabetes, we spend more money on strips than on insulin. So it only makes sense that you can find an interesting way to bring down these costs. And I feel that it's possible. Once you know what the problem is and you put your heads together, you should be able to look at it. Maybe with the lens that has a solution.
Okay, thank you. That's extremely wise. And hopefully we can also engage with, industry. I think we can't have them as our enemies. So we need to obviously bring everyone to the table and find reasonable, ethical, equitable sort of compromises, I think. So Stephen, if I could just ask you for your sort of 1 minute quick takeaway from the Lancet series.
Oh, definitely. I think my 1 minute is going to have 2 parts into it. So I always work within what is the cheapest test frame. That will always be my closing line. What is the best buy for you? Look for that and see how you can weave that into like what is supported by your national insurers and goes into policy, comes into guidelines, comes into protocols that everyone uses. And then, of course, the integration gambit can never be left out. So think cardiovascular, renal, and metabolic. Don't think kidney by itself. Don't think, put in your HIV programs, piggyback on whatever is working. Thank you. That's my 1 minute.
Thank you. So I have 2 or 3 minutes now just to wrap up. And I think, Stephen, you mentioned, and I think both of you mentioned that the patients need to be in the room. The patients need to be present because it's not just us as clinicians or ministries of health doing things to people. And very interestingly, I was privileged to be at the round table that GLOPAC hosted at the World Health Assembly 79, which was co-hosted with Thailand. And there were many different countries, and I was really just representing a European view at that point. But I met in person Marisol Robles, who is a patient. She's a person from Mexico living with kidney disease for many, many many years, and she's the head of her father's foundation, the Mario Robles Osa Foundation in Mexico. And she really stressed to me the role of patient organizations in this entire implementation process, which I don't think was fully stressed in this Lancet series, and it is key. And basically what she said is a diagnosis can change a person's life in a matter of minutes. But learning how to live with kidney disease is a process that can take years. And basically, from the patient perspective, patient education really must be considered as part of care itself and not just a simple addition. And so for her, she basically states the value of screening depends on what happens next. And she thinks the time gained through this early detection only becomes a real opportunity when people have access to knowledge, support, and the tools that they need to take action. So I really feel that her words for me are extremely powerful, because we so often think, we have machines, we have detection, we have knowledge, we have medicines on the shelves. The patient also needs to understand why they need to come back to the clinic, why they need a blood test, why they need to keep taking these medicines. There's maybe little out-of-pocket expenses. One needs to try to explain to them how those may be good buys for themselves. Because basically, as Marisol said, patient education and emotional support are not secondary components of implementation. They're essential for implementation to succeed. And I really feel, for me, that's critical. And I think just the very last thing, Stephen, you were mentioning that Kenya is focusing on prevention. And I think we cannot forget that kidney disease is a disease that is often at least exacerbated, if not precipitated, by many of the social determinants of health, which are underlying structural problems worse in many of the lower resource settings. And so there as well, I think for the governments to understand that the best buys are really the actual primordial prevention of diabetes, of hypertension, of HIV, of malaria, so that the kidney risk is even reduced, because of that. And those we know are very, very good buys. So would either of you have one last comment? Otherwise, I think this has, to me, been a wonderful, very short snapshot of the Lancet series. I do believe the papers are open access as far as I know. So I think, anyone interested, please log on, look at the papers, because basically it summarizes data for advocacy. We can all use this data for advocacy, but not forget that this is a big family made of patients, doctors, ministries of health, and clinicians everywhere, especially primary care. Thank you. Over to you, Leanda.
Thank you so much, Valerie. The collective input from yourself, June, and Stephen really, really emphasizes the role that GLOPAC plays in the kidney health community. We are a collective that is led by the patient, and we're really happy to have Marisol and John, who we spoke about, Stephen, part of our steering committee, and their insights, expertise, and lived experiences really help us to shape our programming so we can do a great job encouraging the integration of patient experiences in implementation of some of the interventions that we talked about here. So I'm hoping that everyone listening in, watching, is inspired to engage with the Lancet series, to engage with various other global strategic frameworks to see how they can apply them to the conversations they're having with policymakers and work together as a multi-stakeholder family to find solutions that we so desperately need for our communities. Really encourage everyone to keep engaging on this topic. The Lancet series is available and it's open access. Like Valerie said, you're also welcome to scan the QR code you see on the screen. The first one will give you access to all 3 of the papers. If you scan the second QR code, you'll have access to a webinar we did on the burden of kidney disease on women. That covers some of the content of the second paper in the Lancet series, actually. And then for people who are part of our community, who are interested in being a part of our Kidney Health Expert Patient Advocacy Academy, encourage you to please scan the last QR code. There you'll find a form to nominate yourself or someone you know who's part of your family or your community who's either living with kidney disease or who's a caregiver for someone with kidney disease. This academy is really excellent at upscaling our community, giving them the resources, the ideas they need to do a better job engaging policymakers on some of the advocacy, advocacy related activities you're doing in your countries. And that's happening in September. If you don't have time to scan any of these QR codes, don't worry. All of these resources are on our website. And there's also a lot more for you to chew on if you spend a bit of time perusing that site. And if you want to engage with us, we encourage you to please stay in touch. Visit us on LinkedIn and Facebook and on X. There you'll get updates on our upcoming webinar, which should be in a couple of months. You'll also get access to the webinar on in your inbox if you're subscribed to our newsletter. I want to thank you, June, you, Stephen, and you, Valerie, for doing such a wonderful job. We are privileged to have nephrologists and advocates like yourselves in our community. Please connect with them on LinkedIn and various other platforms to, stay abreast with the work that they're doing, which is really, really wonderful. Until our next webinar, goodbye and have a lovely day.